Nick Majerison here. Welcome to Top Med Talk. And on today's Top Med Talk, we have a piece presented by Alison, Holmes, Professor of Infectious Diseases at Imperial College London, Fellow of the Academy of Medical Sciences, and a Senior Investigator at the National Institute of Health Research. The piece is called Perioperative Antibiotic Stewardship. If you want to hear the full presentation, simply check out the show notes on topmedtalk.com.
Top Med Talk.
What on earth are we doing about antimicrobial stewardship? So, multi-professional, oh my goodness. We've only started recently in the last couple of years involving nurses and pharmacists. Huge amounts that can be learned, particularly in roles in HIV and TB. Masses of work, huge, complex work, and nurses and pharmacists. We've run programs for pharmacists. The development of roles in Australia and the US are so enormous, and yet in the UK it's only taken us the last couple of years to drive this forwards. And this is colleague Esmita Sharani, who's at the moment working in Kerala with an amazing group of pharmacists, Amrita Hospital, looking at antimicrobial stewardship. Nurses, largest workforce in the world. We need to be using them more. Absolutely extraordinary, and we need to be doing much more about this, and lots is happening in this space, which I'm pleased to report, and real movement to engage nursing leadership in antimicrobial stewardship. Fantastic, lots happening there. However, those are the multi-professional angles of this. You know, fantastic, let's work with our nursing colleagues and let's work with our pharmacy colleagues. More has been done about that than actually working with your other clinical specialties. So just quite extraordinary. Cross-specialty clinical engagement has been pretty appalling. So this is data looking at 60,000 abstracts from state-of-the-art international conferences. So, and this is the amount of times that anything about antimicrobial use or resistance was discussed. Now, of course, I'm an infectious diseases specialist and think that, infectious diseases people are the brainiest, non-single organ type of doctors, and they need to know not only all about the patient and be so clinically up there, they also need to know all about the organ, etc. And, of course, they're the ones using the most antimicrobials at the top there. But what really, really I find terribly anxiety-provoking is that, emergency medicine, they're not too interested in it. Hematology and renal medicine, dear God, renal medicine, not talking about it. When you think that, hematology, bone marrow transplant programs in Italy closed down because of the problems of antimicrobial resistance, and yet hematology not talking about it. Transplantation, renal transplantation would be impossible, and yet we're not talking about it. So I think that's pretty interesting. It shows how terrible we are. And this is a big questionnaire around the world on asking surgical teams. I think it's a little bit pathetic that nurses don't feature there, anaesthetists don't get mentioned there. I appreciate they might be under intensivists, but even so, I think this is really not too great. I think we could do better. And we haven't even got to patients, by the way. I mean, I'm not covering that there, but that's something we're really interested in and have done a lot of work in. And interestingly, that papers are being rejected in the UK because they didn't think it was relevant to talk about patient engagement and involvement within secondary care about antibiotic choices. Extraordinary. Anyway, surgical specialties responsible for a huge amount, and there's been a large paper in the Lancet about what would happen in the modelling around if we even lost a little bit of sensitivity, the impact on surgery and on cancer. Quite extraordinary, and most around the perioperative period, of course. So I just want a little bit about local NHS experience. Surgery, there are patients using it for far longer. We are seeing also poorer compliance. We're seeing horrible outbreaks of carbapenem-resistant enterobacteriaceae costing millions. And the other thing is, we need to move away from thinking that it's all about surgical site infection. It's not. There are many other infections. And the other thing we need to think about is the complete overdiagnosis of hospital-acquired pneumonia, and that antibiotics have a diuretic function. So that overdiagnosing of pneumonia is something that perioperative experts really need to get involved in. And what's become clearer and clearer is that it's not just the choices and it's not just the diagnosis. It's about how all of that decision-making is being made, and can we understand it a little bit more? This has led to some really nice qualitative work, and it was a real pleasure to work with Liam and now Ramani, looking and trying to dissect out a little bit more about where is the decision making. So this paper is, I'm just putting up a few points here, but it was a massive kind of qualitative study, a lot of ethnography in this, and of course it came up yesterday with somebody talking about pain management, about being peripheral to the role of surgeons. It was extremely disjointed, and there was a lack of clarity around decision making, which absolutely undermined effective use of antibiotics and the expectation that it could be given to other professionals. So there is a real role for thinking about perioperative medical specialists who could take on this role of looking at how best to use antimicrobials. So much opportunity there. There's also a very, very kind of complex causal mapping, which also shows the role where prevention and antibiotic usage can come together and where perioperative medicine could have a real impact. This has also led to a much larger scoping piece of work internationally about where are the gaps in decision making. And we picked up again about this issue about lack of clarity. There's also an issue about who's taking responsibility for prevention. And also, we absolutely need to know a little bit more about the culture and team dynamics. And that is context specific. How we make diagnoses, really important. And the other thing is, as I mentioned before, some of this is a problem with lack of access to antibiotics. And we may think this is a developing world problem, but can I just remind you, within the NHS this last year, we've had the most enormous problems with the most basic antimicrobials and shortages. And I'm sure within your own trust, you've had to radically rethink how you use antibiotics, and from tazocin to gentamicin shortages. So just coming back to the ELMIC context, this is completely going to undermine healthcare. I cannot stress enough that particularly gram-negative resistance will undermine the delivery of healthcare. It will absolutely not only devastate clinical outcomes now, it will completely interrupt our capacity to innovate and take things forwards. An enormous problem. A big paper in 2018 in The Lancet by Bicard et al. Showed the massive problem that this is and how infection is one of the largest components of these poor outcomes in post-surgery in this large African study. Okay. I just want to pick up on this issue about surgical site infection and a huge attention on what can be done to prevent infection. We need now to do a lot more about what we can do to optimize antimicrobial prescribing, which will have an impact not just on that patient, but on your next patient and also on society at large. And I think it's time that we move away from just looking at SSIs and do a lot more. And I'm delighted that we've got funding from the ESRC, and this makes a real difference at Imperial, where people aren't known for doing social sciences. And this is a nice collaborative piece of work with South Africa, India and Kerala, and also with our expert anaesthetists, who there are very few of in Rwanda, also working with us. And very pleased to be working also with Ramani on this, and I hope in a year or two's time she or others will be able to come and maybe talk about this at this meeting again. Thank you very much indeed for having me.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.